So my name is Latib. I'm an interventional cardiologist from Milano. And the session today is on practical approaches and novel technology to optimize left main procedural outcomes. I always like to repeat the title just in case you thought you were going to a mitral session. You're not. We're going to talk about left main. Okay. And I have to admit, I have a disclaimer about left main intervention. And my disclaimer is that I really like doing left main intervention, and I really like teaching it. I mean, when I get given a left main to do in the cath lab, it's the highlight of my day because it's really the great cases to do from an operator's point of view, from a technical point of view, but also, patients really benefit from left main intervention. So why a session on left main? A session on left main because more and more so, left main intervention is becoming part of the guidelines. If you think about not even that long ago, in 2010, we didn't have a clear indication that we could do left main. The European guidelines have moved on quite dramatically, thanks to studies like Syntax and the sub-studies from Syntax, to where we now have even a class 1 indication for PCI if patients have a Syntax score that's low, class 2 if it's intermediate. But that's going to change. I think the indications and the class is going to change, and it's going to change because of one study in particular, the Excel study, because this is the first real well-powered study for left main intervention that compared stenting to bypass surgery. And I'm only going to show you one slide, because this session is a practical session, so I'm not going to show you a lot of data. This is the one data slide you get to see. Okay? And what you see on the slide is that when you look at 3 years, there's no difference for death, myocardial infarction, and stroke. Okay? If you do good left main intervention with PCI, you get as good outcomes as bypass surgery in patients with low to intermediate Syntax scores. So that's kind of from the data point of view, that's the take-home message. But I don't want it to come across either that left main intervention is easy. There are challenges that are particular to left main that makes it different from other lesions. There's a large area of myocardium at risk, and that's probably the most important. It's a large vessel. 75% of left main diameters are between 4 and 5.75. When you stent the left main, you often have to come back all the way to the ostium, and you often have to treat an autoosteal lesion, and that adds some complexity to the procedure that we'll try and highlight during the cases. Often the lesions, not just the left main, involves a bifurcation, about 80% of lesions. So you're not just dealing with a simple lesion, you're dealing with a bifurcation lesion. Even though it's large vessel, there's a large area of myocardium at risk, so you need to have a good strategy and understand what you're doing in order to get good outcomes. And then little tips and tricks we'll try and teach you during this session, which we hope will be useful when you go back and do left main intervention in your center. How to avoid damaging the stent if the stent protrudes into the ostium, how to make sure your guide catheter doesn't damage the stent. But the other part I want to highlight, this is a Medtronic symposium, and why is Medtronic interested in left main? Well, because I think we have to realize that in treating left main, for the reasons I told you, the fact that it's a large vessel, the fact that the guiding catheter may touch the stent, that not all stents are created equal. I mean, they may be good when it comes to clinical outcomes, but they're all structurally very different. If you look at something like longitudinal stent deformation, and this is really important in left main because the stent comes all the way to the ostium, so our guiding catheter can easily damage the stent. And so knowing which stent will have less longitudinal stent deformation when you have to cover and go all the way back to the ostium is really important. And these stents are different, so you need to know that. The other important thing is, I mentioned to you 75% of left mains are really large. They can go up to 5.75 millimeters. So we, until recently, didn't have stents that were 5.5 millimeters. What we did was we took 4.0 stents and we expanded them with 5.0 balloons, 5.5 balloons, to try and get them bigger and to try and make sure we had good stent apposition. The problem with that is if you overexpand a stent anywhere, it foreshortens, so it becomes shorter. So you can actually have lesions where you thought you were precise and covering the ostium, but when you post-dilate, you're actually missing the ostium because the stent is foreshortened. Also, as you overexpand stents, you change their structure, and you may change their radial strength, and you may have less radial strength, which could result in different clinical outcomes. The other thing I wanted to highlight a little bit, and these images I show you now are available on the internet, and we've learned a lot about left main intervention from clinical cases, but also from this project called the Visible Heart Project, which you'll find on the internet. There's a whole library of imaging. This is done at the University of Minnesota, and what they do is I'm not sure how well that's showing there, but they reanimate a pig heart and then do procedures on those coronary arteries with angioscopy. And you can really see how stents behave inside a coronary artery. And the reason I show you this in a left main session is because I've learned a lot from two pictures in particular. And I'm going to show you just two pictures from the left, from this, from the visible heart. Here's the one on the left. Okay. When I saw this picture is a picture that convinced me about the importance of doing the pot. Okay. When we treat particularly large vessels and large left mains with a large proximal bifurcation, the stent may often not be well opposed. And when you try and then recross, this is what happens. Look at the picture on the left, what happens to the wire. The wire goes under stent struts. And you correct that by doing a pot. So you'll see our colleagues today show us doing a pot in their clinical cases. I wanted to show you this picture, which really for me highlights the importance of having good stent apposition. You can imagine that if in this left main, your wire went under the struts and into the side branch, and then you dilated a balloon to kiss, you would completely damage the stent. So the objectives of this session is we're going to learn from 3 clinical cases about the contemporary treatment strategies for left main bifurcation lesions. We're going to understand the importance of using dedicated drug-eluting stents for large vessel treatment. We want this to be very practical case-based, so we've chosen 3 different cases that highlight different aspects and challenges of left main intervention. Because in the end, there are different types of left mains. Not every left main is the same, not every bifurcation is the same, and so you need different approaches based on the anatomy. Some approaches will be more simple, some may be more complex. So what I'd ask you to do, because this is going to be an interactive session, we're going to stop at different parts during the case and allow you to make a comment or tell us what you do in your practice. But as you see the cases, I'd like you to think about what your strategy will be. And I think having success in left main intervention is all about planning a strategy. So think about, when you see the angio, what is the Medina classification? Where is the disease? Is this a true, non-true bifurcation? How is the plaque distributed? Is the side branch, a circumflex branch, an important branch? Should the operator be concerned about that closing? What is the angle? Should that impact what strategy we do? The size, how important that side branch is to the patient, and the amount of calcification. Because all these variables will impact the strategy that our colleagues have chosen during that case. So without further delay, we'll start the first case. And like I said, rather than having discussion at the end of the case, we want to integrate your discussion during the case and allow you to share your experience with us and tell us what you would do in certain cases. So there are unfortunately only 2 mics here. We don't have any roving mics, but I'd ask you to use the microphones, or even, it's not a big room, just use your voice and tell us what you do in these cases. Thank you.
Okay. Thank you, Asim. I'm Oscar Mendiz from Buenos Aires. Without any further delay, I will introduce the first speaker, Dr. Darren Walkers from Australia. He's going to speak about left main provisional stenting with POT.
Okay, thank you, Chairman, and thank you for allowing me to present this complex left main disease patient. This is about how we manage the patient and the lesion for an optimal outcome. I think that's what we heard during our introduction there. So this is the patient, an 81-year-old male. He's a cattle farmer. He's still working on his property. He's becoming increasingly short of breath. He has severe aortic stenosis, preserved left ventricular function, severe left main coronary disease. He has an abdominal aortic aneurysm with laminated thrombus and severe peripheral vascular disease. He is a smoker. He's stopped now, but he has severe chronic airways disease, FEV1 of 0.68 litres. He's had a previous stroke in the context of paroxysmal atrial fibrillation. He's on rivaroxaban. He has some other comorbidities that I've listed there. This is the angiogram. Left main disease, severe, distal, calcified, a trifurcation, in fact. This is the RAO caudal projection. Here's the cranial. You can appreciate that this is critical stenosis. It's calcified. It involves all 3 branches. You can see the level of calcification before we fill. You can see calcification in the aortic valve. Moderate disease to the right, which is dominant, but nothing critical there. This is the echo, severely restricted leaflet motion, severe aortic stenosis. So, some discussion. Complex case, lots of issues here. This, of course, was discussed with the heart team. Cardiac surgery was declined. Severe COPD, severe peripheral vascular disease. Not a surgical candidate for AVR and coronary artery bypass surgery. His Euro score, 6.3%. Seems relatively low, intermediate risk. STS PROM 4. Syntax score calculated only 20. Kind of patient who would do very well with stenting, but this is a complex lesion. Syntax 2, which takes into account a number of clinical characteristics, showed dominance for PCI over bypass surgery. So some questions for you, for the audience, questions that we needed to face in managing this patient. TAVI, or PCI, or both. Would anyone think of treating patients' aortic stenosis and not treating their left main disease, treating their left main disease and not treating their aortic stenosis? Probably not. The role of revascularization. We've heard that patients could be randomized for revascularization pre-TAVI. It's controversial, but would anyone not treat his left main stenosis? The role of balloon valvuloplasty. Is this a strategy for improving the safety of stenting in this situation, or is it not required? Is TAVI in fact feasible? How would you deliver a transcatheter valve in this patient? We cannot go transfemorally. He has a severe peripheral vascular disease, an abdominal aneurysm with laminated thrombus. We cannot go transapically or transaortically because he has severe lung disease. This leaves carotid. He's had a previous stroke, largely recovered, but would anyone risk going the carotid access route in this patient? Subclavian possibly as our only option. And would we stage this? Would we do a PCI first, then TAVI? Would we do TAVI first, then PCI? Or would we do it all at once? Lots of questions to ask. Access is clearly a big issue for this patient. If you're going to just do the PCI in a staged fashion, maybe you do it radially. Brachially, perhaps, if you're going to do a combined balloon valvuloplasty and percutaneous intervention. If you're going to do a lot together, you may need to go the subclavian route in order to get satisfactory access to deliver a transcatheter valve. Would you go percutaneously or via cut down? What is the role of mechanical support? Can you do a balloon pump in this patient? Impeller? Would you take a single or multi-stent strategy? How do you deal with anticoagulation, antiplatelet therapy? These are all the issues.
So Darren, maybe before you tell us what you did,
yes,
because we're all dying to know. Maybe I'd love to hear from the audience, and we've got Oscar in the audience as well, who will maybe try and get some idea of what people would do.
So these are the issues. These are open for comment. We need to solve them if we're going to treat this patient and get a good outcome.
So we have a complex patient, elderly patient, peripheral vascular disease. He's got an aneurysm. He's got a left main, significant left main. I think we don't need FFR here, Darren, don't you think?
We don't need FFR in this patient, I don't think.
I mean, it's pretty critical left main with severe aortic stenosis.
Maybe the first question would be surgery or endovascular. Maybe we can pull the audience. Who would send this patient for surgery? Raise hand. One.
So the rest of you, all PCI and TAVI?
The second question would be stage or in the same procedure? Stage?
Would anyone do this in one procedure? That's ambitious, probably take you all day, but would you do the lot together?
All together? Which is the position?
Contrast volume may limit you.
Right, exactly. The challenge of doing it all in one procedure is the amount of contrast, the complexity, but you could possibly use one excess then, right?
Yeah.
And do it all from one excess. If you were going to do, for example, percutaneous transaxillary access, you could then do your stenting, your balloon, and your valve all from one excess. It's a bit complicated. It's a longer procedure for the patient, but you would have a challenge.
Here, we have a comment.
So whenever we have severe AS and we want to treat the left main, obviously the concern is that the risk of performing the left main angioplasty is increased, correct?
Yes.
So what if we go in, put a guider in the left main and a wire, and just do a balloon valvuloplasty? Okay, reduce the risk, If we don't have severe AR, which is not going to happen more than 95% of the time, then we've reduced the gradient across the aortic valve, then we perform the left main, and then come back because of the diload and do the TAVI later.
Okay, so a staged procedure, balloon valvuloplasty preceding percutaneous intervention, valve insertion in a staged fashion. Sound sound? Any support for that approach?
And
You would put a wire down the left main where you're doing the balloon. Why would you do that?
Yeah, because wire down the left main so that, and then if I have severe AR, then I need to take care of that first and put a balloon expandable valve, okay, avoiding the left main. And with my wire in there, continue the job. In other words, protecting the left main while the valve.
Okay, these are important considerations because it's quite complex, right?
So, Darren, do you have any preference about balloon valvuloplasty first, stenting, and then stenting after? If you were going to stage this, would you always balloon before stenting?
Yeah, I think it's a good question, and that it comes down to what is the chance that you're going to render the patient hemodynamically compromised during your intervention. And the problem with left main is, you know, any hypotension will not be well tolerated, and the spiral with severe aortic stenosis could be fatal. So in this situation, I would always do balloon valvuloplasty prior to intervention to improve the safety of the intervention. But that's controversial. There's no evidence for that. There's nothing more than anecdote and our own personal experience. You won't find any randomized trials to tell you the answer. But balloon without the valve, PCI, staged intervention.
And the other issue is when we have a combined situation on coronary aortic stenosis, and in some cases when we do a stage procedure, the patient get asymptomatic. So this is a real issue that surgeons sometimes ask you where you are going to proceed with the TAVR procedure in case the patient gets asymptomatic. What is your comment?
It's difficult. You have both conditions that we know can produce symptoms, and he has quite significant symptoms. We have both conditions which we know are prognostically important. These conditions are lethal, untreated. So I think it's very difficult to say, let's treat one and wait and see the other. Tough strategy. You know, death may be the first presenting symptom if you try that approach. So it's a tough one. I think you need to fix both these lesions. They're severe and critical. But we might need to move on in view of the time. I'll tell you how we approach this. Our intervention was, our overall treatment strategy was combine balloon valvuloplasty and revascularization left main, followed by stage transcatheter valve implantation via an alternate access route, really the only route we have, which is his subclavian. And our plan to do the PCI, so this is our plan, this is how we're going to do the PCI. Happy to hear how you would approach this. We're going to do a brachial cut down because we need to put a 10 French teeth in, and we need to have a long 10 French teeth around to the ascending aorta to do valvuloplasty safely via the arm. We're going to perform balloon valvuloplasty and then PCI. And the strategy that I took was to take a provisional single stent strategy, rotational atherectomy to ensure debulking of the lesion, so that we could adequately expose the stent. Proximal optimization technique, followed by kissing balloon if required, provisional 2-stent strategy or 3-stent strategy if required, and provisional IVUS. Very difficult to pass IVUS up front in this patient, followed by stage 2 left subclavian transcatheter valve replacement. This is the brachial access, obtained, large French sheath, 10 French sheath down into the ascending aorta, balloon valvuloplasty is performed. Here's an 8 French EBU guide in case we need to take a multi-stent strategy. Maybe we need to deliver 2 or 3 stents here in this situation. Workhorse wire to the LAD, exchanged out for Corsair microcatheter, rotor support wire, rotational atherectomy to the left main. This is followed then by workhorse wires to secure the major vessels and a 3.5 millimeter by 15 millimeter semi-compliant balloon at reasonably high pressure. The intervention, Renato wire to the circumflex, BMW to the LAD. A resolute onyx stent 4.0 by 18 millimeter to the left main. What is the advantage of the onyx stent? Deliverable, visible, excellent side branch access, at least 4.0 side branch access, minimal foreshortening. These are the branches, QCA'd. Proximal optimization, important part of left main stenting, as you've seen. Here's a 4.0 by 8 millimeter non-compliant balloon. Here's a 5.0 by 6 millimeter non-compliant balloon at 20 atmospheres. Comments or questions at this stage? This is the result after proximal optimization.
And your stent did not, obviously your stent is within the ostium.
Stent is within the ostium ending in the mid-body. Yeah. Healthy ostium, yeah. So would anyone do any more from here?
So there was a question, I had someone say IVUS from the audience, which I think is not a
bad suggestion.
suggestion.
I think had it not been such a long and complex procedure, I probably would have IVUS'd. I think it's a good question.
Right.
This has been well expanded though, and an excellent angiographic result, good on clear stent. There is a principle to keep it simple, swift and safe. That's important in left main stenting. And at this point, if you follow the European Bifurcation Club algorithm, if you have a good result, you could stop. We have good result on the circumflex and ramus, excellent flow, well opposed stent, proximally optimized up to 5.0, which is pretty much towards the limit. 4.8 of the 4.75, 4.8 of the onyx stent is certainly at the QCA'd size for this left main. The procedure can be stopped, which we did. Rivaroxaban and clopidogrel for this patient. So one anticoagulant, one antiplatelet agent. Subclavian cut down and transcatheter valve replacement in a staged fashion. This patient went home day 3 after transcatheter valve replacement. It's well at 6 months. So, complex left main intervention is increasingly common. Our older patients have complex high risks that we need to manage, particularly in the TAVI era. We obviously need to plan the patient and the lesion very carefully. We've undertaken a provisional strategy, prepared for multi-stent intervention if required, pot and kiss principles applied. Questions or comments?
Okay. Maybe we'll take one comment before maybe moving on to the next one. Great presentation. Thank you, Darren.
Just one quick comment. You asked if there is anything anybody would do differently at the end of your stent. I wouldn't. I think it was a superb strategy, excellent result. But there's always that controversy, which is, do you open the cells into a big circ so that if you want to access the circ later for a lesion, do you want to actually get on with it and do it now rather than do it later and reactivate the restenosis cycle in the left main? That's always a question that has no answer, but I wouldn't do it here.
So maybe we'll just ask the audience, would people routinely kiss in this kind of bifurcation where you had a good result with provisional and pot? Routine kiss, put up your hands. Okay. Leave the result as is. Okay. So majority will leave it as is.
There's really no right answer. You endanger the circumflex, you may end up having to stent it if you dissect it. You leave stents across the ostium if you don't. Thank you.
Okay.
Great. Thanks,
Thank you so
Darren.
much.
Thank you very much.
So next speaker is Dr. Hee-Soo Kim from Republic of Korea. He's going to speak about complex left main requiring 2 stents as intention to treat. Dr. Kim, thanks so much.
I prepared 2 complex left main cases requiring 2 stents as the intention to treat. Disclosure. Why I did select this case is to suggest you paradigm shift on left main bifurcation PCI with new DS. In the old era, there are limitations in technique lesions. 2-stent technique was worse than one stent, but now in our large registered data published in a couple of years ago, there are no limitations in the bifurcation PCI nowadays. In other words, the performance two stent technique was equal to one stent technique. Left main, non-left main equal in prognosis. That's the reason why I prepared these two cases with intentional systematic two stent technique for true left main bifurcation lesion. 76 years old male with new onset chest pain. ECG was good. Baseline angio shows left main distal 90%, circ os severe, LAD os significant. Then this is the frozen image of spider view of this case. How do you choose the stent technique, seeing such kind of lesion?
So maybe we'll open it up to the audience again. So you saw the lesion. We have a distal left main stenosis. There's a stent already in the LAD. There's disease of the ostial circumflex. And I think really the discussion is, when you're thinking of this, one stent versus two stents. Anybody have a comment?
Would you like to comment?
You said
Two stent.
two stents?
Yes.
And why two stents on one stent?
Medina 111.
So true bifurcation. So true bifurcation, Medina 111. So maybe two stents. Would anybody do provisional one stent?
Doubtful.
Seems
Maybe
like-
we can ask the audience if they would have used imaging or FFR. Some of you would have used FFR? No, everybody's okay with the angio?
I think everybody's convinced it's a critical left main. Sorry.
Would you like to use the mic? Thank you.
I would use IVUS in this case to establish the dimensions of the stents.
So maybe IVUS to look at if there's any under-expansion or what size stents you're going to use pre-IVUS. Okay, good.
In this case, actually, FFR is contraindicated because it is a severe symptom, and we can see the significant lesion. There is no need to do FFR in this case. Significant stenosis, true bifurcation lesion, when we choose the two-stent technique among 4 or 5, T, Culotte, mini crush, V-stenting, or kissing stenting, please check the size or significance of side branch. It's very good, big enough. It's value to salvage this side branch. That's the reason why we choose two-stent technique. Which one? To consider the angle between two vessels and comparative size between two vessels, LAD versus R6. In this case, angle is acute. In this case, you can choose two, mini crush or culotte. If the size is comparable to each other, I prefer culotte. If size is discrepant, I have to do mini crush. Compatible size between LAD circ, culotte stenting. POBA, LAD, POBA R6. This is angio after balloon valvuloplasty. We usually perform IVUS at this stage after POBA for the safety of the patient. Then first, circ, because the alignment between left main to circ is less favorable. It is tougher to advance the second stent. The second stent should be deployed in LAD with better coaxial angle between left main and LAD. That's the reason why I usually stent first with side branch less favorable angle. Onyx 3.5. Then I usually perform adjunctive ballooning with the same stent balloon at highest pressure for optimal apposition at left main, as well as highest dilatation of circ ostium. That is really hard lesion. If after kissing ballooning, usually we can see the expansion at the circumflex ostium. That's the reason why I usually perform adjunctive ballooning at highest pressure with same stent balloon. And then I perform rewiring through the circ stent strut cell toward LAD and inflate circ stent cell toward LAD for the passage of second stent from the left main to LAD. Then second, LAD stenting, Onyx 3.5 by 26, followed by adjunctive ballooning with the same stent balloon at highest pressure for optimal apposition at the ostium of LAD as well as left main for the next passage of wire. We usually have to save the used balloon catheter in one PCI procedure because government strictly regulate the number of used balloon catheter. Thus, I don't do a part with separate balloon. Then rewire into circumflex and kissing ballooning to LAD and circ, sequentially at highest pressure and simultaneous inflation at the nominal pressure. And I usually finish the procedure by such kind of kissing balloon part without touching the carina if the balloon length is different, using balloons 3.5 by 15 and 15. In this case, both balloons are same in length. Thus, I can cover the left main ostium as well as I can touch the carina because both balloons are the same in length. This is final angio after culotte stenting at left main bifurcation lesion, followed by final kissing ballooning. We can see the ostial flare-up using kissing ballooning. Let's see divers here, left main. Even though we used kissing ballooning, eccentricity is acceptable. That's the reason why I do final kissing ballooning and kissing balloon part rather than using another bigger balloon for proximal part. The second case is 71 years old male with recent onset chest pain.
Dr. Kim, can you go
Okay.
fast, just in 1-2 minutes?
ECG was normal. This is baseline angio of second case. True bifurcation lesion with significant stenosis. How do you treat this case? This is frozen image. Just go. Okay,
Yes,
okay.
yeah, please.
Once again, this is a true bifurcation lesion with side branch is significant. Thus, I think side branch should be salvaged with separate stent. That's the reason why I prefer two-stent technique from the beginning. Which technique? The angle is obtuse, then just T-stenting, regardless of comparative size between two dot vessels. T-stenting, POBA, circ first. Please see the balloon catheter is inside the LAD. The purpose of this balloon is shown in next slide. Here, secure os coverage is very important in T-stenting. Thus, I inject dye during the inflation of circumflex stent to guarantee the ostial coverage. Adjunct ballooning with stent balloon with highest pressure after subtle withdrawal for optimal dilatation of circ ostium. Then withdraw the balloon and ballooning of left main to LAD to press struts that may be protruded to left main for easier passage of second stent from left main to LAD. This is angio after circ stent and LAD ballooning. Then I advance Resolute Onyx 3.5 from left main to LAD and inflate the second stent covering left main ostium, and adjunctive high pressure ballooning. Rewiring into circ, kissing ballooning with different size of balloon, 3.5, 3.0. In this case, the balloon, the same length balloon is not available. Thus, I have to use different length of balloon for final kissing balloon here.
How high of a pressure
Usually, we perform 14 atmosphere.
for the kissing?
Yeah. And kissing balloon part here, we have to adjust distal mark of both balloons because the length is different between two balloons. The longer balloon is inside, extends inside the guiding catheter, no problem. In this case, please avoid the touch of carina. This is kissing balloon part. It's a kind of strategy to save one balloon catheter. Final, we can see the flare-up of left main ostium. As in conclusion, left main bifurcation PCI with UDS is a little bit different from the over-the-air. In our meta-analysis or register data, we confirmed efficacy performance of two-stent technique in UDS is exactly the same as one-stent technique in left main as well as non-left and subset. Thus, my take-home message is don't hesitate to do two-stent technique for left main disease. With big circ, it's valuable to be salvaged, having segmental, not focal, segmental, a significant lesion.
Okay.
Thank you very much.
Congratulations.
Maybe we'll just recap what we saw. So, I think we saw two really interesting cases of when you need two stents, and I think we saw two examples, important circumflex, true bifurcation, Medina 1-1. We also saw how to choose different techniques based on the bifurcation. So, once again, even if you decide to use two stents, you can't always use the same technique on every bifurcation. So we saw here, I think, the impact of the angle on choosing a culotte versus T-stenting. And I think we also saw how to save balloons, which in many countries, that is an issue. You need to think about resources, and I thank you for showing us your tricks about how to save balloons. A lot of us would have just taken new balloons and taken non-compliant balloons, but sometimes there are resource issues that we need to take into account. So maybe if there are any questions on these two cases before we move on. Oscar, do you want to make any comments? No?
No, I think it's a great demonstration, a new way to do POTS, and maybe I learned something from Argentina, as you mentioned. We have to save balloons sometimes. I don't know. We have to prove. But maybe my question is, how are you so sure that you are not distorting the ostial segment of both vessel when you are post-dilating proximally?
I'm sorry?
After the kissing balloon, actually, you do the pot with the two balloons. How are you sure that you are not distorting again the true bifurcation? Do you IVUS after the pot with the two balloons?
Thus, to save the ostium of either LAD and circ, first find a kissing balloon for each ostium of the two vessels. And final pot using two balloons, I always avoid touching the bifurcation area to do any further distortion of the bifurcation stent.
Okay. Thank you so much. Just move on to Dr. Ziad Ghazal from Lebanon. He's going to present a provisional case with significant residual stenosis of the circumflex requiring crossover to the two stent techniques.
Okay, so I had prepared a case and changed it because this one is more interesting. I did this one last Friday, so 5 days ago.
We would like it.
Off the press.
So I thought this is probably better for this session. This is a 53-year-old, very healthy gentleman who's a professional cyclist. He has dyslipidemia. He's a cigar smoker. He has a history of high CT coronary calcium score and a negative stress echo 2 years ago. This time, he develops new exertional chest pain while cycling, and he cycles the mountains several kilometers with his group. The echo showed a normal EF with very subtle distal hypokinesis. this is his left spider view. And as you can see here, quite a bit of calcium. I'm not sure if we can, do we need to dim the lights a little bit in the front? Or actually,
can
we're
see
okay.
perfectly.
You can see them.
Yeah,
okay. So this is the bifurcation. You can appreciate a very tight osteal LAD, moderately tight circumflex ostium, and the ramus, which is also tight, but moderate-sized vessel is not huge. There is also here a tight lesion in this big marginal, as you can see, and unfortunately, the left anterior descending artery looks bad. Okay, so the question was, obviously, surgery is always a good option if the LAD was a better target. And that's the right. The right has a lesion in this moderate size left ventricular branch, as you see here. This one would be easy to do, but obviously we have more serious problems to consider. So heart team approach, even in this situation, I would never just go ahead with an angioplasty. It's important to talk to the surgeon, even though the LAD is clearly not bypassable. And of course, the surgeon said, take a shot at it. I'm not going to do this. The syntax score actually amazingly high, but remember, syntax is back in the old days with taxes. So we decided to go ahead and perform an angioplasty. Can we open it for discussion now?
Yes.
We would love to do that, yeah, please. So
this is angioplasty, this is not surgery. So what would people do here? So what would people do? How would you approach this?
Once again, Dr. Khaled, which is going to be your approach?
Distal left main, it's a true 1-1 bifurcational disease. There's significant disease in a large obtuse marginal distally. I think what I'd first do is treat the distal disease in the circumflex, get that
distal in the
circumflex obtuse marginal branch,
yeah.
Get rid of that, get that out of the way. Then I think this would be, for me, a 2-stent upfront strategy. I'd use IVUS to confirm the size of left main, the LAD, and the circumflex, and then probably end up using a DK crush technique to treat it.
Okay.
Any different opinion?
And what would you do, Khalid? You didn't mention about the LAD.
Distal LAD? Not touch it. Also, Khalid is rushing away.
anybody else?
Anybody
other
else?
approaches to the? Would anybody treat the LAD? I mean,
We have a yes here. Yeah.
Can you show the other view as well? Because I think it shows that the LAD is subtotally occluded as well, right? Just about in the mid part.
Maybe slow flow or, yeah.
Do you have another view?
Of the septals, let's see.
Yeah, this one, yeah. So look at the 20/20 view and look at the LAD on the curve up there, which is not that distal. I mean, that's mid-LAD, and it looks subtotally occluded. Remember when we look at the cranial, it always foreshortens the LAD, and the stenoses seem very distal, right? So always look at the 20/20 in this view, and the part on the curve there, with the LAD curves, that's still mid-LAD, and it's a good-sized vessel. It's subtotally occluded. Would anybody treat that?
Yeah, you can go.
Yes, we had. We had to treat the LAD.
You would treat the LAD?
Yes.
Okay. So LAD stent, circumflex stent, and then we tackle the left main? First left main.
Okay. Any different opinion? Oops, excuse me. I hit somebody.
Okay, so well,
Okay.
Anybody
Move
else? Okay, I was not going to do the LAD, but of course he's a cyclist, and if he comes back with symptoms, it's always hard to know. And then you don't know what the culprit really is. I mean, he has an osteal LAD is tight. The LAD mid-distal is very tight. The circ is tight. So if you leave something behind and he's a cyclist, he's going to go back cycling. There's no question about it. So we started with the distal LAD, ballooned it.
So can I ask a
Yes,
question?
please.
One of our audience said, you know, you have a really critical left main. Why don't you just deal with the left main and get rid of the major ischemia risk area now, and then worry about the distal vessel?
Yeah, good question. I still like the rule of putting the most distal stents first. And this left main is going to take, you know, a 2-stent technique. Although my title is provisional, you could think of provisional for the you know, because the ostium of the circ is not tight. But if you want to think of a complex 2-stent technique, you don't want to shove more stents into that to go into the distal. So that would be my approach. On the downside of this is that you are passing stents in a tight left main to ostial LAD, but you can balloon that first. So you balloon that without stenting it, and that's what we did. 7 French from the groin. I've never done a 7 French from the left radial. Of course, you could do that with a special catheter if the artery is big, but it's better to ultrasound the radial first if you want to do this. Wired both arteries, ballooned small to big to get a good size. Didn't have the right bioabsorbable scaffold for that type of lesion, although the data on the bioabsorbable scaffold, as you know, especially in very calcified vessels and small vessels distally, is not coming out to be very good. Dilated also with a 2.5 balloon, the entry point, and started stenting. This top stent in the mid-LAD, actually where you were pointing out, 22 atmospheres and the waist was still there. That made me a little bit anxious because you don't want to leave anything behind, you know, when you put so many stents. So we, you know, 26 atmosphere with a short balloon, high pressure balloon, and remember shorter balloons give you more distending pressure focally, and ending up with a very good result. He had chest pain, he had distal closure, which may have been, I don't know if it was no reflow, I doubt it, or maybe spasm with nitro. He got better. Okay, so then we did the marginal. That also took high pressure to 20 atmospheres to get rid of the waste, although maybe there is a minimal waste left there. And then we started working on the left main. So do we have time to take more questions? So how would we now tackle the left main? Khalid, you said you will do a DK crush. Okay.
So who's going to keep it simple and just do provisional? Anybody? Provisional? And what would make you, if I could ask, treat the side branch? So you'd start provisional?
I start provisional and I would dilate first the side branch and then put a stent from left main to LAD and then go to kissing and then see what it happens.
And if the result's good, you would leave it. What would make you put a second stent in on the circumflex?
I would put a second stent if the result is not good. Or at IVUS I have some dissection and so on.
Thank you. Anybody? No? Same? Okay.
Yeah, so that's obviously not wrong. It's something to consider. And but you said you would dilate the circumflex. You would, or before, after the stent? Okay. Well, we had in mind to actually stent both, but I think provisional is not wrong because the ostium, we haven't messed with it yet, and it looks okay, and we can treat it in a provisional way. But we had in mind to do both, so we dilated it, a bit of a waste here, but we went with higher pressure balloon and were able to do it. Opened the LAD with a 3.0 balloon and then positioned this stent in this location And remember here, the ostium of the left main is free of disease, and there is really no point, just like the first case we saw, there is no point going back to the ostium if the ostium is free. Just give yourself room later on if you have to recath the patient to avoid getting entangled into the struts of the left main. So that's a 3-5. Why 3-5? Obviously the left main is bigger, but why 3-5? Because the distal will not take, the proximal LAD is not going to take a bigger size than this. So this is how it was positioned. And this is the result after a POT. Well, that's really not a POT. That's an NC in the stent all the way to the proximal part, and then 4.5 8 millimeter NC balloon in the proximal end of the stent. And then that's the result. I mean, conceivably, even though I have dilated the circumflex ostium, this is a stable result. We could stop there. But you know, you've recycled the watch-of-free stenosis on that ostium of the circumflex, you know, because you've dilated the lesion with the balloon.
So quickly, show of hands, who would stop and say, okay, I'm done, great result? Okay.
Interesting.
Who would put another stent in?
The other issue would be how many people would stent in until the ostium of the left main? Some of you? Or do you agree with this strategy?
Who would not stent to the ostium of the left main? Okay. Do you feel differently about that, or?
I usually cover everything.
Yeah. My concern is coming back in with the guider for later work. I mean, this patient is 53. He's going to have more things done down the line. So this way, we're not going to worry about it if we engage it with any catheter. So anyway, but it's interesting that most of you would not do anything at this point, and I totally respect that, because I think it's... What would you do, Azim?
I wouldn't do anything, I have to admit. I would leave it alone. The angiographic result for me is acceptable, and I'll justify why I say that. You know, for me, the most complex part about left main, okay, and where I'm still unhappy with the results, is the ostium of the circumflex. That's where we get the most restenoses. And so, if I can avoid stenting the ostial circumflex, I try to avoid it.
Right.
That's my opinion.
If I was going with a provisional stenting strategy, and I agree that if I had not dilated it with a balloon, I might agree with that. But the fact it's not a short lesion. You've got at least 15 millimeters or more of disease extending from the ostium of the circ into the proximal circ, and I've already balloon dilated it with a balloon. I'm not so sure at that point. I think I'm committed to stenting it.
So can I be controversial? Every time you do kissing inflation, you're ballooning a part of the artery, okay, with just balloon, and you don't stent it. So if that were true, every single time we did kissing, we should stent.
With the provisional stenting strategy there, usually you're aiming just to open up the struts. You're barely in the vessel. Here you put 20 millimeter balloon, 18 millimeters into the circumflex. It's a little bit different.
Okay.
We have to move on.
Thank you.
Actually, the distal circ lesion was focal, less severe than the proximal circ. Then you put the stent distal, avoid the proximal stenting. It's totally against the rationality.
So say that again. The distal circ is tight, right?
No, focal, not so severe.
Yeah.
If you measure the FFR,
it's
the
not so severe.
Yeah, focal is very less ischemic, but the segmental lesion is very important. Thus,
I mean, it's a tight lesion.
But that should be treated with balloon, while the proximal circ should be treated with stent.
So we have a third approach.
Okay. Okay. So just to move on,
very quickly, Darren.
Just a brief comment. Just with these very calcified vessels, sometimes you don't get good expansion of the stent, and I can see both stents you've placed, the one in the LAD and the one in that marginal. There is still significant residual waste that you can see with the naked eye. It'll look worse on IVUS. And I think you got to get an optimal expansion of the stent in those locations. So I'm putting a plug in for rotational atherectomy in very calcified lesions like this?
Yeah, although rotational atherectomy, especially if you use a 1.5 burr, would modify the lesion enough, but not to have the stent fully expanded. I think fully expanding a long stent is going to be a challenge. So anyway, let's just move on to close. We recrossed and dilated. We recrossed and dilated with a balloon. Did a kissing balloon inflation, did a pot technique by using a 3.5 by 15 stent in the ostium of the circ. This is called snug tap, which means it's like a snugging. So if a balloon inflated to low pressure in the left main to properly position the stent, and then a final kissing by pulling that balloon back, and that's the final result. Now let me just conclude by saying the back and forth that we had about whether or not to keep it at provisional and one stent technique versus two. In my mind, the downside of putting a stent, which is what we did, two stent approach, is that you risk the ramus even more. Okay, so that's one of the things to consider. But also, anytime I put a stent down in that branch, I like the course to be wide open as much as possible proximally. So, you know, it's sort of, everything sort of balances out in your mind and you make a decision. But I don't think it's wrong to keep it at one stent, but we ended up sort of with two stents.
Right.
Okay.
Congratulations.
Thank you.
So, Oscar, we unfortunately only have 2 minutes, so maybe you want to quickly summarize for us in 2 minutes?
Yeah, I will try to go to the last slide, and that's it, because we have discussed almost everything. I try to be on time. What I was trying to show you that is, left main is important to be revascularized. Then, you have to be sure that you have a severe lesion. We have discussed about the use of IVUS and FFR, especially not for the cases that we have today, but especially when you have some ostial lesions. So also the use of IVUS to guide PCI when you decide to do PCI to identify and solve complications has a positive impact. When we use IVUS in several publications, you have a better survival. The risk stratification when you are deciding between coverage of PCI, we can use different score, but the hard team approach, as the guideline recommend, is maybe the good strategy. Provisional stent is so far maybe the best strategy, but we have the paper from Dr. King that we had to review from the experience from Korea about two stent technique. Today we have seen excellent cases with two stent technique. Now we have a little bit more support about the evidence after the Excel trial, as Asim pointed out at the beginning. And of course, last night, very late in night, I received a meta-analysis publication in a circulation intervention where you can see the left main intervention has lower stroke rate, lower myocardial infarction, and similar outcome to the long-term outcome. So again, we had to discuss the cases with the hard team, but doing like you did, an excellent show, you can have excellent outcomes. You have to use, of course, second or third generation stent to have the outcomes that we have. And of course, these patients are going to do well. And congratulations, maybe you can close. After, I want to invite to see cases from Latib and not Dr. Colombo.
Okay. Thank you. I hope you all take some practical advice home on left main intervention, and thank you for coming. Bye-bye.